All right, good morning, everyone. Welcome again to Friday Grand Rounds. And it's my pleasure to introduce a relatively new addition to our faculty, Dr. Nima Nurde. He is a Toronto native and completed his residency at University of Ottawa Eye Institute, followed by his fellowship in cornea, anterior segment, and refractive surgery under Dr. Kashif Beg in Ottawa. So he currently works at St. Joseph Health Centre and Trillium Health Partners, and specifically in the area of cornea, cataract, and comprehensive ophthalmology. And he ran across me because of his interest in refractive surgery. In fact, he's a colleague of mine now at my center, and that's where he had the, let's say, fortune or misfortune to bump into me and say, is there anything he could do to help me out at the residence program? I said, well, now that you mention it, I'd be delighted to have you participate in our grand rounds on Friday morning. So I gave him all year to prepare. Thank you very much, Nima, for joining us this morning, and welcome.
Thanks, John. Thanks for having me. So we're going to start off with, so we have a few cases, 3 cases, and these are meant to be just kind of random cases that come through the cornea clinic. Some of them are more common, some of them are less common, and just going through a review of reviewing our approach to managing these and highlighting some key points, things to make sure we don't miss. So first, we're going to start off with Ellie. Ellie's going to present the first case.
All right, great. So I'll just go ahead and share my screen here. Okay, and everyone can see okay? Great.
Yep, that's perfect.
All right, so I'm just going to be presenting a case of cross-linking for keratoconus, and the topic is going to be, can we have too much corneal flattening as a result? And just wanted to thank Dr. Nurde for providing the case and all the details and tips for the presentation, and to the department for the opportunity to present as well. So jumping right in, we have a 54-year-old male with keratoconus in both eyes. And this was diagnosed back in Syria. And as per the patient, although we don't have the exact notes, he had cross-linking with Intacs done in his right eye, and then cross-linking and PRK done in his left eye, all back in Syria in 2009. Otherwise, he's diabetic, dyslipidemic, and has some prostate problems. And he presents because his main issue is that he finds, specifically in his left eye, his vision is just continuing to get worse and worse since he's had this cross-linking done. So luckily, he actually brought his pentacams with him from Syria. So this is a pre-op pentacam of his right eye from 2008, a year before he had the procedures done. And if you look at the top left corner on the screen here, you can see the sagittal curvature of the cornea. And this shows kind of the classic type of inferior steepening that you see in keratoconus cases, corresponding with some thinning as well below. And then looking at the elevation maps, the top right being the front of the cornea and the posterior elevation below, you can see that there is some elevation of both anterior and posterior cornea. And then if we have a look at the left eye as well, again, a similar picture where you see that inferior steepening on the curvature, as well as a bit less maybe elevation on the right eye, but still some elevation at the front and back of the cornea. So now fast forward a few years in 2014, and that's the first time he was seen here in Canada that we know of. And this wasn't by Dr. Nurde, it was just by some colleague, and we were able to get the notes. So we can see that in 2014, his corneas looked good with the Intacs in the right eye and was clear in the left eye. And you can see his manifest refraction there, still a little myopic in the right with some astigmatism, and then much less so in the left. So now at this point, the patient returns a couple of years later in 2016, and really he's just coming back complaining that his vision is continuing to get worse and worse in that left eye. And if you have a look at the refractions here, you'll notice that the right eye is pretty stable compared to last time. But in that left eye there, he is starting to tend towards some hyperopia, being a -0.5, sorry. before, and now shifting up to a +2 of hyperopia in that left eye. So at this point, we repeated the pentacam on both sides, and a slightly different layout than the other one, but here the curvature is just in the bottom left corner, and the elevations are across the top here. And you can see the right eye compared to pre-op is relatively stable. And then if we pull up the left eye picture, you can see, again, looking at the curvature down in the left bottom left corner here, that there is some more kind of flattening indicated by these cooler colors here. And as well, looking up at the elevation curves of the front and back, there is also less prominent elevation than before. So we'll continue to kind of go along the story here. So again, 2 years later, coming back, and again, just continuing to complain of worsening vision. And if you look at his refraction again, right eye relatively stable, left eye pretty similar actually, maybe a little bit worse than in 2016, but not by maybe half a diopter or so, but nothing too significant. And then 3 years later, but now in 2021, so his most recent visit, continues to complain of dropping vision. So as you can see, this is the trend here, just that left eye getting worse and worse and worse. And on slit lamp exam, really not too much to find. His cornea continues to look nice and clear, and nothing obvious there that would be accounting for this change in vision. But now when you look at his refractive error, he has continued to progress in terms of hyperopia, now from a 2.5 back in 2018 up to a +4 in that left eye in 2021. So really, since we've seen him back in 2016 and even dating back to 2014 when he was first seen here in Canada, he has had this gradual worsening of his hyperopia. And again, we're not exactly sure what happened in that interim period from 2009 to 2014 before we first saw him, but presumably he was even more myopic to start and kind of continuing to worsen. Now, unfortunately, at this visit, the patient did decline a pentacam, so we're not sure exactly what his cornea looked like, but yeah. So I know that was a lot of numbers, a lot of refractive errors that was presented. So just to kind of sum up basically where we've gotten to this point. So this gentleman, specifically focusing on his left eye, had the corneal cross-linking and PRK done back in Syria in 2009. His preoperative Kmax from the pentacam that he brought was 43.8. And the postoperative Kmax up to 2018 at our most recent pentacam was 39.8. So he's kind of had this gradual slow reduction in Kmax over the years, and probably would have even been greater by 2021 if we were able to have a pentacam. And then what's quite significant as well is that he's reported this drop in vision, and we can see how much his refractive error has again slowly changed over these years, going from minus a half diopter when he was initially seen all the way to +4 with some astigmatism in 2021. So interesting to see his left eye kind of continuing to progress there, and throughout all this, his right eye, the refractive error and vision have essentially remained stable. So at this point, I'll just take a brief step back just to do a very, very brief overview of collagen cross-linking. I know this is a procedure that most people have probably heard of and are familiar with, so I won't, beat it to death. But essentially, the purpose here is to strengthen the cornea by inducing cross-links in the stromal collagen. And the key components of this procedure are having some kind of photosensitizer, most commonly riboflavin A, and UV light to kind of induce these reactive oxygen species and induce that cross-linking in the cornea to really stiffen it up. And although there are a few different indications for cross-linking, really the most common one that we come across is to halt the progression of corneal ectasia, and most commonly keratoconus, just by virtue of that being the most common. And in terms of how people do collagen cross-linking, there have been a lot of different protocols developed, starting with the Dresden, and then now there's multiple protocols, epi on, epi off. So again, won't go into all the details, but just to know that there are a variety of ways that collagen cross-linking can be done. And interestingly, because a lot of these patients, at least preoperatively, have some component of, or a significant component of refractive error, there are people who are combining it with PRK or intra corneal ring segments to improve the kind of corneal operations and refractive error in these patients as well. Now, unfortunately, like any procedure, collagen cross-linking does have some side effects. And one of the most common side effects that we're probably all familiar with is corneal haze. Now, this is, in the literature at least, quite common, and in the vast majority of cases, it's transient. And most of the time will just kind of resolve on its own as the patients heal post-operatively, but sometimes it can persist and remain significant. And in one reported study, up to 2.8% of patients did have some corneal scarring. And some patients also develop corneal infiltrates, whether they're sterile infiltrates or infectious infiltrates. And the bottom right corner is not one of our patients, but just a picture showing some corneal haze after cross-linking. And then just continuing on with some other side effects, some patients will experience delayed re-epithelialization. Reports indicate around 2 to 5% even. And in a few of these, it'll just kind of persist onto a persistent epithelial defect. And the last little thing there to touch on, just because our patient had combined PRK and cross-linking, is that there's this risk that maybe if you take off a bit more of the cornea with PRK, you could lead to some thinning and instability. And there have been some reports of progression of keratoconus after this. However, looking over the literature as a whole, it actually seems to be a pretty effective procedure at kind of improving some of the refractive errors that patients do have as a result of keratoconus. So now getting back to our case a little bit in terms of the corneal flattening. So corneal flattening post cross-linking. So this is actually something that happens in quite a fair amount of patients after cross-linking. In some studies, up to 50% of patients will experience some flattening and decrease in their Kmax. And sometimes it's actually a good thing because patients are so steep to start that if you get that cornea to flatten out a bit, it can actually help their refractive error in vision just by virtue of the flattening. And looking through the literature here, there seems to be a kind of a wide array of the amount of flattening reported. For conventional cross-linking, some studies report that in the patients who did have flattening, it was up to a diopter at 12 months. Some even reported up to 2.5 at 3 years. And then, of course, if you do the combined cross-linking PRK, because you are shaving off a bit more of the cornea, you do tend to get even more flattening there. And then just to note, because people are using accelerated cross-linking as well, it does seem to induce less corneal flattening. And, so this is kind of the normal trend, but some patients do experience extreme flattening or this kind of prolonged course of flattening. And really the main risk factor that was identified in the literature for patients who are going to have really long or prolonged or extreme flattening is just having a high baseline Kmax, typically above 50, sometimes even greater than 54 was the main risk factor. And there have been some cases of reported really kind of either progressive long-term or really rapid corneal flattening. So there was one small case series that reported up to 10 years of continued flattening, up to 9 diopters, and one report of a patient who had 14 diopters of flattening just within the first year alone. So I guess the question at this point is what do we do for this patient? So back to our patient, I guess we were a little bit stumped into how to best help this patient who's having this continued flattening of his cornea, because you're not too keen to do refractive surgery, just given how much that cornea is changing. And looking through the literature, at least, there's no evidence to say if you re-cross-link this patient, you're going to be able to stop that progression. So at this point, we've just kind of offered him contact lenses and continuing to monitor. And I should mention the interesting thing with our case, because this gentleman had, this prolonged corneal flattening over a few years. In the literature, almost all these patients had quite high Kmax values, above 50. But in our case, the patient's initial Kmax as per their pentacam was only about 44. And despite that, they had this kind of continued flattening. So just kind of an interesting note to point out there. So curious to see if anyone has experience or options in terms of the management of these patients, and happy to answer any questions.
Great. Thank you so much, Ali. That was great. Yeah, I mean, you summarized it quite well. One, there's a few questions, a few unknowns. One is, what protocol did this patient have for cross-linking? And unfortunately, given the time and place that they had the surgery, we're unable to get those records. So that I don't know. But it does pose a bit of a challenge, because in this case, the patient's kind of done a little bit of research, so asking all the right questions, and asked if lens-based surgery, IOL surgery, is an option. And given the cornea is changing, I don't, that's not a good option, because it's a moving target. The patient has, of course, intracorneal ring segments in the right eye, and he was wondering if maybe that could be put in the left eye. Well, of course, I explained to him it has the opposite effect, has a flatten. The reason we use it is to kind of try and flatten the cornea. So in this case, yeah, I mean, at this point, I suggested contact lenses and monitor, and keep our fingers crossed. Hopefully things stabilize. At this point, he's about 12 years out, and things have so far continued to flatten. So I'm not really sure if anyone has any suggestions in terms of why they think this is happening, or what they can do for a case like this. I'd appreciate it.
I think Alan's got his hand up.
So I think, first of all, great case. First of all, Ellie, I think you did a wonderful job at presenting that, and thanks, Nima, for making this possible. But the first question I have is, he's 54. He's had this 11 years ago, so he was 43. We know keratoconus is not just a treatment, cross-linking rather, is not a treatment for keratoconus. It's a treatment for progressive keratoconus. And by 43, you would have thought that he probably would have cross-linked his own cornea already. Although you can get progression at any age, it's unlikely as you get older. So you got to wonder why he had the cross-linking in the first place. It's an atypical cornea that will continue to show progressive changes, ectasia, at 43. The second thing is that, one eye had an intact and one eye had refractive surgery. Although not always the case, but you expect both eyes to act similarly. So the only difference is that one eye had actually addition of an intact, and the other eye had treatment which removed part of the cornea, and that's what's led to the progressive destabilization of the cornea and continued flattening. We know from the original studies by Seiler that flattening, you can get, I think Ali, you mentioned it, 10 diopters plus a flattening, which can continue longer than 1 year post treatment. And it seems like for some reason, the combination between the collagen cross-linking and the refractive procedure has led to this continual destabilization of the cornea. Until, I agree exactly with what you're doing, until you get a stable cornea, no permanent treatment like refractive lens exchange would be a good idea, because you're trying to hit a moving target. My feeling is, I think you're on the right track. I would continue to push either glasses or probably contact lenses, because I don't think he'd manage the anisometropia. I think I would certainly support what you're doing.
Thank you, Alan. I appreciate that. And yeah, as you said, you can get continued flattening. There have been case studies of long-term flattening beyond 10 years. But as Ellie mentioned, most of these, if not all of them, have very steep corneas to begin with. So, if your Ks are above 50 and then you get them to your, let's say 42 afterwards, these patients might be pretty happy. In this case, unfortunately, because he wasn't that myopic. His cornea wasn't all that steep to begin with. Now it's quite flat, so that's why it's so hyperopic. But yeah, I mean, we just have to. And sorry, one other thing that came across the literature was they discussed that eccentric cross-linking may potentially lead to corneal flattening. Again, in this case, you know, I don't have the reports from the surgery to know if the cross-linking was central or not. But either way, yeah, no, it's a tough case for the patient. Hopefully things stabilize. With contact lenses, I think you'll do pretty well. But again, it is a bit of a moving target.
So it's a comment more than a question. I just want to thank you for that case, because cross-linking has really revolutionized in some ways our approach and security in performing refractive surgery. We feel like even if we do get a problem, we have a treatment that's far better than what we used to have, which could result in the patient having a corneal transplant. But here you illustrate that cross-linking is not always so benign. Is your suspicion rather, given that it was in 2009, that he probably had a fairly aggressive cross-linking protocol like the Dresden protocol? Oh, and I also wanted to see, Ellie, could you put up his original slides of when you were saying that keratoconus was first diagnosed? Because to me, it didn't look that bad. And I'm wondering if you know what his refractive error was back then.
I do not have his refractive error back then. He basically just had a folder with his scans that he brought with him. So he didn't actually have his chart, just his pentacams. And
do you want me to go ahead and share my screen again? Sorry.
Yeah.
Just to show that.
And the in terms of you know,
just to Alan's point that, you know, he was 43. Maybe he would have, in this case, it'd be better if he had been left alone with, maybe he just had some mixed astigmatism.
Yeah, no, I agree. In this case, for his left eye especially, I mean, yeah, I think he, you know, unless there was documented progression, I would not have suggested anything, especially, you know, looking back 12 years ago, doing a combination of cross-linking and PRK seems a little aggressive for back then. Now we're doing kind of more and more of it. And even that, we're being very cautious with how much PRK we do. So, you know, I was a little bit surprised to see that like 12 years ago, this was offered to a patient in an eye like this.
Okay, great case. Thank you.
Thank you. And thank you again, Ali.
Thank you, so everyone.
So next up, we have Ahmed. Ahmed's going to be presenting a case. I'll just hand the podium over to Ahmed.
See the slides? Good morning, everyone.
Yep, we can see them.
Okay. I'm Ahmed, one of the PGY3 residents at the University of Toronto, and I'm going to be presenting a corneal case today. And the title is When It's More Than a Corneal Problem. History was that the cornea service received a consult about an 89 years old female referred for corneal thinning in the right eye. And subjectively, she complained of progressive eye pain and blurry vision. She was treated with Vigamox for a month prior to coming in, and then referred to an ophthalmologist who saw the corneal thinning, started on Pred Forte 4 times a day, and referred to the cornea service. In terms of past ocular history, the patient had cataract surgery in both eyes in 2016, and past medical history, patient had hypertension, dyslipidemia, osteoporosis, and those are the list of medications, no known autoimmune diseases. And on exam, the right eye vision was 20/60, IOP was normal, no APD, and conj exam showed 2+ injection temporally with conjunctival thinning, with adjacent temporal corneal thinning from around 8 to 10 o'clock, crescent in shape, with an overlying corneal epithelial defect. AC showed 2+ cells and was deep, and IOL was in the bag. Fundus exam was also normal. Unfortunately, I don't have the slit lamp photos of the anterior segment before management. Those though were the fundus photos that showed no vitritis, no retinal, chorioretinal lesions, no vascular sheathing, no disc edema. So nothing to be noted on the fundus exam except for some extramacular, small to medium discrete drusen's. So at that point, the impression was obviously there was peripheral corneal thinning, and on top of the differential diagnosis was peripheral ulcerative keratitis, and the differential for that could always be infectious neoplastics or Amora's ulcers which is a diagnosis usually of exclusion. So we sent an extensive metabolic and inflammatory workup, CBC, renal function test, ESR, CRP, and antibodies, ANA, ANCA, rheumatoid factor, and anti-CCP, and also added some infectious workup such as syphilis serology, NHS X-ray, and ACE, and a rheumatology consult too. So the case was managed as a PUK, so we started prednisone 50 milligrams a day with an H2 blocker to protect the stomach, doxycycline given the thinning, and we stopped the prednisone, the topical Pred Forte, and started Vigamox given the epithelial defect, and we managed the ocular surface too with preservative-free artificial tears. So on 1 week follow-up, the patient has improved subjectively, and the clinical picture was stable. And she was supposed to follow up the week after, but she did not show, and it was during the pandemic. She was not able to arrange transportation. So, and she also missed her rheumatology appointment. So she showed up later, 2 months after the previous follow-up, and she has significant increase in pain. She did follow the planned prednisone taper course, and she was on 20 milligrams at that point. Vision was 2200, and those are the photos from the 2 months follow-up. And the conjunctiva, you can see it was pretty injected and engorged conj vessels. There is thinning in the previous area, which was noted 8 to 10, but however, at this time also, there was new areas of ulcerations from 4 to 7 with an extensive epithelial defect, basically inferior nasal and temporal. The AC was still deep, and it was 1+ cells. So again, the impression was PUK with worsening peripheral thinning. So we upped the prednisone back to 50 milligrams, and we asked for an urgent room consult to consider IMTs. On 1 week follow-up, patient was already seen by rheumatology, and rheumatoid factor came back positive. So they started him on methotrexate. And at this point, she started improving significantly. So improved pain, and conj was less injected, eye less inflamed, and the ulceration though still looked stable, and the epithelial defect was active. However, on the 2nd week, the epithelial defect did heal completely. Vision was 20/80, and she has really significant improvement of pain. So again, I'm just gonna touch briefly on PUK. So it's an inflammatory etiology, pretty rare actually, 3 cases per 1 million per year, and distributed equally between males and females, very highly associated with autoimmune conditions, and most commonly with rheumatoid arthritis, 35 to 40% of the cases. Other autoimmune diseases associated with PUK is polyarthritis nodosa, inflammatory bowel disease, other collagen vascular diseases such as lupus and relapsing polychondritis. And actually, the second most common etiology of PUK, other than rheumatoid arthritis, is the ANCA vasculitides, most commonly granulomatosis, polyangiitis, and less commonly Church-Strauss and microscopic polyangiitis. So clinical presentation was exactly how the patient in our case came in with severe pain, tearing, and light sensitivity. And usually there's a juxtalimbal crescent-shaped stromal thinning with an overlying corneal epithelial defect. And actually, probably even majority of the cases do have associated scleritis. And unfortunately, it can lead to corneal perforations if it's severe and with severe corneal melting. The workup, again, that's what we asked for in our case: CBC, creatinine lights, and inflammatory markers, including antibodies. And always to keep in mind infectious causes, especially if there's an atypical history or on a clinical exam you suspect an infiltrate. In those cases, you can probably add a corneal culture too. The differential diagnosis, Morin's ulcers is on top of the differential, and just a few clinical features that are different between Morin's and PUK. With Morin's ulcers, you get less conjunctival involvement, and although you can have like limbal injection and limbitis with peripheral corneal ulcerations, but basically the differentiating feature is the scleritis. Both can present as uni or bilateral, and more is basically a diagnosis of exclusion. Infectious causes, neoplastic if the history was less acute, more chronic, and some other atypical features. Terrien's marginal degeneration present with circumferential thinning. However, there would be no epithelial defect, and patient usually is asymptomatic with a different age group too. Medical management, we manage again the ocular surface with topical antibiotics and artificial tears, preservative-free artificial tears. Actually, treatment in PUK is systemic with prednisone, 1 milligram per kilogram per day, the recommended dose, and majority of the cases would need IMTs, and those are different types of immunosuppressive medications that could be used. Again, rheumatology consult is really urgently needed and early on in the course, because with PUK you don't worry about the eye only because of the associated autoimmune diseases, which can have a really high morbidity and even mortality in some cases. And always avoid topical steroids in any case with corneal thinning. Surgical management is not too specific to PUK, but managing perforation or pending perforation with corneal glue, keratoplasty, different types of keratoplasty depending on the clock hours of thinning, depth of thinning, conj or scleral thinning involvement too. So lamellar, crescenteric, tectonic, or corneal scleral transplants if needed. Conj resection is something that could be considered, and my understanding or the theory behind it is to reduce the cytokines and inflammatory mediators from reaching the temporal cornea and limbal cornea to prevent melting. So basically removing those blood vessels that feed the immune mediators. Few take-home messages. It was just a quick overview. So PUK is associated with systemic autoimmune diseases, which again, it's more than an eye manifestation and needs systemic treatment aggressively. Early rheumatology consult is always advised, and we need to emphasize compliance with treatment with those patients, because as we know that cornea can perforate, plus it does have high morbidity and even mortality in some cases. So yeah, PUK is more than a corneal problem. Thank you for listening, and we're open to questions.
Thank you so much, Ahmed. So, PUK is something that we all at some point do see or will see in our offices. A couple of the key points that you mentioned. I would not start these patients on topical steroids that can lead to perforation. I think it's important to explain to the patients that the eye is one part of it, but really the important thing is we have to find out if there's a systemic cause and treat that. The mortality from underlying systemic cause, I believe in over 10 years, is about 50% if it's undiagnosed. So it's important to kind of get them to see a rheumatologist early on, and so they can start them on another systemic therapy in addition to the steroids as well. Look for any underlying cause. And also in these patients, it's important to kind of explain to them that, even though the eye feels better, just getting you off the steroid is not the solution. We really need to find the underlying cause. So in this case, the patient, she was feeling better after about 2 weeks, wasn't able to come in, and then she kind of waited until things really got worse a couple months later, and then she kind of showed up again. So explaining this to patients early on, making sure they understand that is key.
So there's a question from Jason about starting the oral medication. Are you generally reasonably convinced by your clinical presentation and start it right away, or do you wait for your infectious workup to come back prior to starting the oral steroids?
So yeah, it depends on the case. Like if there's any sign of infection, if I see any infiltrate, anything based on history, if the patient's a contact lens wearer, anything like that, then yeah, of course I'd want to rule out an infection, including culturing. In this case, Ahmed asked if the cornea was cultured. To be honest, there was nothing to culture. There was no infiltrate, nothing like that. There was just an area of thinning. So it really depends on the case. Certain cases like this, where there's no signs of infection, nothing based on history, I like to get the patient started sooner than later on the steroids, just because I really want to avoid a perforation and progressive thinning. And I think Jason also asked about the tapering regimen for the steroids, and that really depends on clinical response. I do tell the patients it's going to be over a few months typically, and I give them an idea because they just want to know, roughly how's it going to look. But I do tell them that it's going to depend on how they respond. So that's why have them back frequently, frequent follow-ups, and taper or change the schedule accordingly.
Alan, do you want to go ahead?
Yeah, first of all, great case, nicely presented, Amit. I think there's most of the time we don't need urgent rheumatological consultations, but I think this is one kind of episode where you do want to get a very, very quick rheumatological consult to determine what's the underlying autoimmune condition. So it's good to have a rheumatologist who you can refer to and who you can get to see your patients quickly for exactly this kind of purpose. What I see more often, rather than the acute situation, is when you get a letter or referral from the rheumatologist saying this patient's rheumatological condition is well controlled, but they're having corneal melting. And my comment is, just think of the eye like another joint. If the cornea is melting, it's not under control. So, they need to go back and rethink it and, modify the systemic immunosuppression. And I agree with you, Ahmed. This is a systemic condition manifested in the eye. And unless you treat the body, you're not going to get improvement in the eye. Just two quick comments also is that one of the things, I am always concerned about when I see a scleritis or a corneal melt is for one of the, I think it's called GPA now, but it used to be called Wegner's. Typically, it will occur in a younger aged individual. And, if it goes into the kidneys, the patient can die. So it's really important to pick that up early. And it's treatable and it's reversible. That's number one. The other thing is that I think what happened with her symptoms, probably why she didn't come back, is she was doing well on the 50 milligrams of prednisone. I think she became symptomatic and her ocular problem got worse when she started tapering because, as we talked about, this is a systemic condition. And I think the 30 milligrams of prednisone was not adequate to keep her, to prevent further corneal lysis and peripheral ulcerative keratitis. So I think one of the things you might want to tell patients is that, if the symptoms get worse when you're tapering the steroids, it's a possibility, and just let us know. So great case, a lot of good learning points.
So there's one more question from Amrit. Why do we think the topical steroids cause melting or thinning, whereas the oral steroids do not?
That is a good question. I do not know, actually. I don't know if anyone from the, if any of the other panelists know.
it probably just inhibits epithelial healing a little more than systemic would. And I think, you know, it's just, if there's any problems on the surface, it may exacerbate that. I think that's the main reason, but there are cases where sometimes people do use topical steroids and it helps a little bit, but I agree with exactly what Ahmed said, don't use topical steroids, and I agree with what you did perfectly, Nima. Great cases, thank you, sir. You the man.
It's been a long time since I've seen a case of PUK. Is methotrexate typically the next step, or are other newer, fancier rheumatologics more common, or what have you seen?
My understanding is it depends on the underlying cause. So for example, in rheumatoid, methotrexate is kind of the go-to. And that's been my experience and my understanding. It really depends on what the underlying cause is, and there's different medications that are able to target those more effectively.
And there's some of the biologics have been worked on, and I don't have a list of all of them, but I know that some of them have been approved for rheumatological use and can work also for peripheral ulcerative keratitis. Again, through the same mechanism of quietening down the overall systemic inflammatory condition.
Yeah, I think it's really, I agree with you completely, Nima and Alan. Rheumatology has to be involved ASAP because it's a bit of a process getting them through all these medications, the steroid-sparing agents. You know, many patients cannot afford infliximab or rituximab, you know, right off the bat, and they have to kind of go through and prove that they've failed methotrexate, azathioprine, MMF, cyclosporin, and then they may get some compassionate care or government care SAP for the biologics. So yeah, that's the process I've seen. But again, excellent case.
So we better move on. I guess you have another case, Nima, is that correct?
I do, yeah. Thanks for everyone's feedback. So I'm just going to share my screen here. All right. Okay, so next case is a case of Stevens-Johnson's, and that eventually became toxic epidermal necrolysis. So it's a 41-year-old male that was admitted with a diffuse rash. This started shortly after he began taking allopurinol for gout. Upon admission, he had a 2-day history of a rash. It involved about 10% of his total body surface area. He was admitted to the hospital for Stevens-Johnson syndrome, and he also complained of decline in vision as well as red eyes. So ophthalmology was consulted for Stevens-Johnson syndrome with ocular involvement. On presentation, he had a rash involving 10% of his total body surface area. His uncorrected vision was 20/40 OU, pressures were normal. He did have some lid ulcerations, but they were small. They involved less than 1/3 of the lid length OU. He had some corneal staining, no defects, and a little bit of injection or significant injection in both eyes. Dilated exam was normal. At this point, I began treatment rather aggressively, preservative-free lubrication hourly, moxifloxacin preventatively, lubricating ointment, steroids, cyclosporin, and saline rinse. This might seem like overkill to be this aggressive this early on, but as we know, cases of Stevens-Johnson do tend to progress rather quickly, so it's very important to stay on top of things. 48 hours later, at this point, the rash had gotten worse. We had greater than 30% total body surface area was involved. Patient began treatment on IVIG as well as systemic steroids and supportive therapy. Vision uncorrected was hand motion OU at the bedside. The lids had larger defects involving the lid margins. There were membranes and as well as epithelial defects over the cornea. There was conjunctival injection in membranes. Once the corneal membranes were peeled, the vision did improve and improved to 20/60 in the right eye and 20/80 in the left eye. Again, treatment was maintained, continued with the same drops and pills. However, at this point, it was quite clear that things were getting bad quickly. And you know, I got the sinking feeling that if I just stayed the course, it would be akin to kind of driving off a cliff. So this is the point where you realize you have to really, you know, change your management. Even though I thought I was treating this patient aggressively medically, it was quite clear that in this case, that would not be enough. So now a little bit about Stevens-Johnson syndrome and toxic epidermal necrolysis. These are a spectrum of rare acute immune-mediated diseases involving the mucocutaneous areas of the body. Essentially what happens is we have keratinocytes that die, and when this happens, you get sloughing off of the skin and the mucosal surfaces. Most commonly, the trigger for this is a medication. It can less commonly be from infection. Fortunately, this is pretty rare. We see this about 6 cases per million annually in Stevens-Johnson syndrome, and the more aggressive toxic epidermal necrolysis, we see 1 to 2 cases per million annually. Unfortunately, though, the mortality for this is quite high. It can be anywhere from 35 to 40%, and most commonly the causes of death are sepsis and pneumonia. Ocular involvement is common in the acute phase. The majority, anywhere from 60 to 100% of cases, have some sort of ocular involvement. And anywhere from 29 to 79% of those that survive and get through this whole ordeal have chronic ocular surface issues. And for most people who are able to overcome this, their main problem down the road is related to their ocular surface. So, it's very important to be aggressive early on in managing these patients. Just a review in terms of how we categorize these. So if it's less than 10% of the total body surface area that's involved, we consider this Stevens-Johnson syndrome. Anywhere from 10 to 30%, we call it Stevens-Johnson TEN overlap, and greater than 30%, sorry, 10 to 30% is overlap, and greater than 30% total body surface area is TN. In terms of the pathophysiology, well, it's believed that drug metabolites lead to an immune response, which leads to the release of the Fas ligand, which is a type 2 TNF inhibitor that sits on transmembranes. And once that gets triggered, once the Fas ligand binds to that, it triggers cell apoptosis through a caspase cascade. In terms of the ocular manifestations, this can vary. In the acute phase, it can be anywhere from mild hyperemia to sloughing off of the entire ocular surface. So it can be quite variable. Patients can have pseudomembranes, epithelial defects, lid margin necrosis, meibomian gland dropout. If their lacrimal glands are involved, they can have scarring, severe dry eyes, and limbal stem cell deficiency. They can have symblepharon formation, which can restrict ocular motility. They can have trichiasis, entropion, exposure keratopathy. They can eventually develop keratinization of the palpebral conjunctiva, which can lead to epithelial defects, corneal neovascularization, and corneal conjunctivalization. Eventually, they can, in worst cases, they can get keratinization of the entire ocular surface and loss of vision. So as you can see, it can be quite devastating. In terms of the acute management, few key points. We need to monitor these early and often. So within the first 1 to 2 weeks, every 24 to 48 hours at least. Any membranes or mucus need to be removed with forceps, as well as with a frequent saline rinse. Ocular surface disease needs to be optimized, whether that's lubricant, steroids, cyclosporin, or amniotic membrane. There's lag ophthalmos that needs to be addressed using ointments, dressing, in some cases, scleral lenses. If there's lid margin involvement, that also needs to be addressed. And the best treatment we have for that is amniotic membrane. So Darren Gregory put out this classification about 5 or 6 years ago for Stevens-Johnson syndrome, and it's quite helpful, it's quite good. So here on the left, we have the different areas of the ocular surface that we look at in the treatment. So we have lid margin involvement, cornea, as well as conjunctival involvement, and the recommended treatments are below that. So at the top here, we have the severity of the disease. So it goes from mild, moderate, severe to extremely severe. In the mild case, essentially all there is just mild hyperemia, it's just hyperemia. In moderate, there's some lid involvement, but not much, less than a third of the lid length. And there's staining of the conjunctiva, no greater than 1 centimeter. In severe, and I'm going to group severe and extremely severe together because the treatment's essentially the same. This involves greater than 1/3 of the lid margin involved in at least one eyelid, any corneal epithelial defects, and conjunctival staining larger than 1 centimeter. And the key is once you cross over to severe, so if it's mild and moderate, you can treat these with medications. Once you cross over to severe or worse, then it's important to use amniotic membrane. And this has been a bit of a game changer in managing these patients. So for our patient, that's kind of, at that stage when we were looking over at the edge of the cliff, the patient had lid margin involvement, corneal involvement, and conjunctival involvement. So at this point, it's time for something more than just medical treatment. So amniotic membrane, it's used in severe cases. The key is to use it early, so the first 7 to 10 days. And it can help limit long-term complications. It has anti-inflammatory effects. It has effects where it limits scarring. After that 7 to 10 day window, the effects are much less valuable. So patients tend to get scarring, and the long-term sequelae do tend to persist. If just the cornea and conjunctiva are involved, then you can consider using something like Procara, which we see here in the top right here, that photo. And that really comes prepared. It essentially fits on like a contact lens. You just put it over the cornea. It's easy, fast. The downsides are, number one, it's very expensive, and it doesn't provide any protection of the lid margin or deep fornices. Now, once you have lid margin involvement, then that's when you need to move on to something a little more aggressive, such as a sutured amniotic membrane transplant with a symblepharon ring. And that's what these photos on the bottom right here show. And the pros are, these are nice. They cover the entire ocular surface, including the lids. The cons are, it's challenging to do. It's often done at bedside, and it's not easy. So, when it's done at it's often done at bedside because these patients are often unstable and they're not able to take them to the OR. It's easier if the patients are sedated. If they're not sedated, if they're awake, then that becomes even more challenging because it's suboptimal. The environment suboptimal, as well as the patient can have some discomfort. So what you need for this is a symblepharon ring. You see that in the bottom left. Amniotic membrane. And the symblepharon ring, there's various ways to get that. Here I use an ocularist who provided the symblepharon ring, amniotic membrane, some sutures, and bolster. And in terms of the management of chronic in terms of management of the chronic ocular manifestations of Stevens-Johnson syndrome, really what you want to do is you just want to optimize things. So optimize the ocular surface. If there's any lashes that are abrading the cornea, you want to epilate them. If there's any malpositioning of the eyelids, you want to correct that. Scleral lenses, and if needed, mucous membrane grafting and fornix reconstruction. Now, the thing is, we want early intervention because ideally we want to try and limit the patient having any of these. Once they start having these issues, then they're kind of committed for the most part to a lifelong battle with them. But if you intervene early, you can hopefully avoid this. So back to our case. Patient was seen 24 hours later to have an amniotic graft placed with a symblepharon ring, and you can see the photo on the right here. It's an illustration of how it looks afterwards. At this visit, the vision was a hand motion OU. Lid margin was involved.
Before you move on, could you just describe in a little more detail how you get all that in there? You put the membrane on first and the ring on top. How does it?
Yeah, so that's a good question. So this is tricky. So the way I did it was, first I sutured to the top part of the lid with the bolster. So ideally, you're supposed to go through the entire lid length. So through the entire lid thickness, and you want to see if you can grab the amniotic membrane through the fornix. In the case that I did it, the patient was awake. It was at bedside, so there's a lot of local anesthetic. It becomes a little bit tricky to do that. So what I did essentially was I sutured the top lids using the bolster. So there's amniotic membrane covering the upper lid, and then I placed a bolster to suture that down. And then I basically use the amniotic membrane to cover the entire ocular surface. So follow the superior lid, dig it deep into the fornix, upper fornix, place a symblepharon ring in there, and you want to use the biggest size ring you can get. So I just had them send me all the sizes they had, and the biggest one I could fit is the one I put in there. So it tucks the amniotic membrane deep into the fornix, and then place the amniotic membrane on the ocular surface, and again, tuck it under the inferior fornix, roll it over the inferior lid margin, and then bolster on the inferior lid. So it's a tricky procedure, but I mean, it does take a little bit of time, but in this case, it worked for both eyes. So you just have to have a little bit of patience and make sure the patient's the patient themselves are very comfortable, and there's adequate local anesthetic. So yeah, at this visit, kind of, things had gotten worse. More membranes were removed, amniotic membrane was placed, and usually the amniotic membrane tends to dissolve over about 10 to 14 days. So patient was seen here about 2 weeks later, and here you can see still the patient obviously doesn't look great. Their rash hasn't totally resolved, but their ocular surface looks much better. Keep in mind, they still have a symblepharon ring in the eye at that time. At this point, I removed the symblepharon ring, removed the sutures. Vision was much better, 20/40 in the right eye, 20/60 in the left eye. No new ulcerations on the lid. Cornea was better. The eyes were still injected. Still maintained the same regimen. Fast forward now, I saw this patient about a month.
Nima, can I just ask, did you have to replace the amniotic membrane at all during those 2 weeks? And do you have to sometimes?
So that's a great question, Sharif. So sometimes you do. You do, especially in more severe cases. I did not. And really, I based it on response. At this point, I was checking up on him regularly. Once the amniotic membrane had resolved, there was really no corneal epithelial defects, conj epithelial defects, no active lesions on the lid margin. So at this point, I was comfortable, and the patient was feeling better, seeing better. The other thing to remember is essentially you're, suturing both their eyes closed and placing an amniotic membrane for a couple weeks. And it's, when they're medicated, ideally sedated, that's much easier to do. But when they're feeling better and they're out, they feel like they can see better and they're starting to be mobile, it's very difficult to convince them to suture their both eyes closed. But that being said, in this case, he was doing much better. So the cornea looked much better. The conjunctiva looked much better. So he just needed the one-time treatment. So 16 months later, I'd been watching him in the interim, but most recently when I saw him about a month ago, vision's good, 20/20. He's currently on cyclosporin, BID, preservative-free lubrication and ointment at nighttime. He complains periodically the left eye gets a little red and irritated. There is a little more staining in the left eye, and that just lubricating more aggressively keeps that under control. This is, one of those very rewarding cases because we do see patients where we've seen years after they've had Stevens-Johnson syndrome and, they're still battling with it and they have these significant chronic eye problems. But this, it's nice to know that if we're able to, that we have the tools that if we act quick, we can kind of, help save someone's eyes and make a real difference for their eyesight and their future. And so just very quickly, just review the clinical course. Early on in presentation, looks mild, things progress really quickly, and then you have to act quickly. That's when you place the amniotic membrane. Amniotic membrane dissolves over a couple of weeks, and then over the long term, hopefully, people can do very well with this. Take home points for Stevens-Johnson, toxic epidermal necrolysis. You have to monitor very closely and early on, treat aggressively and rapidly. Don't be hesitant to use amniotic membrane grafting. It can make a big difference. And realize it does take a little bit of time to organize that. You have to contact the eye bank. You have to get the symblepharon ring. So don't wait until the last minute to do it. Be comfortable treating a little more aggressively. And you also need to warn patients that as far as the ocular surface goes, really, this is a long game. Most of them will do well immediately after, but if they get scarring down the road, then this is when, years out is kind of when the significant ocular complications can happen. So it's just important to make sure they're aware of that. And these patients do need to be followed long-term. Lastly, I just want to thank Dr. Clara Chan and the eye bank for providing amniotic membrane on such short notice for this patient. And also Dr. Hall Chu, one of our panelists. He was helpful in giving me some tips and guidance for this and also putting me in touch with Ocularis to provide me symblepharon rings and also web oculars for the symblepharon rings.
Great case to close it out with. The question from the audience: what do we do if we're a community ophthalmologist and such a patient is in our peripheral hospital and there's no one local who feels comfortable doing this? I would imagine the answer is the patient needs to be transferred. but thoughts from Nima or Hall or Alan?
I think any trained ophthalmologist should be able to do this. I thought Nima's presentation was excellent, and it's a great case. We talked about it before, and it looks beautiful, good result. But it's like Nima said, is a chance to make a real impact on somebody. I mean, these people have severe pain and dry eye and blindness going forward, and it's one of those things where it's kind of a heroic thing that did. And a great job, Nima. I really enjoyed that. Thank you.
How friable is the membrane? Is it easy? Like, when you're trying to put the ring in, does it rip or tear, or it's surprisingly stretchy?
It's stretchy as long as it's hydrated. As this procedure can take some time, the amniotic membrane can dry out. If it dries out, then it can become quite friable. Yeah, it's actually very stretchy. So yeah, I didn't have any issues with tearing or anything like that, and I was pretty aggressive with kind of making sure I stretch the amniotic membrane to cover all surfaces of and around the eye.
I'll just offer a counterpoint to that case of someone in a peripheral hospital needing this. I've only seen one of these in my career so far, and I was told that it's not that difficult a procedure to do, but I was pretty happy that Clara Chan and Zale Mednick were there to be able to do this procedure. I'm not sure if it's a procedure you want to do for the first time in someone with a very severe Stevens-Johnson syndrome. And, I really think that these might be cases that should be transferred to a center where you have a cornea specialist that is familiar with this technique, that can repeat the technique when needed. Hall, do you think that general ophthalmologists could do it for the first time? Because you don't see these very often. Without any training and experience?
Yeah, I think you can. I mean, I think you just have to, you can always give us a call and we can show you, like, we can send you videos and show you how to do it. It is very straightforward, but I think you have to think about, yes, this is very important, and obviously it's necessary for systemic reasons. They should come to the burn unit or wherever associated, but most of these patients are extremely, have a lot of comorbidities, and they have a high risk for mortality. And if you ship them from hospital to hospital, it's going to be difficult. Some ICUs will accept, some won't. So, and we had a case recently, a couple months ago, I think, up in Newmarket, where they wanted to transfer down to Sunnybrook, but the patient died within a week. So, I think you have to look at the patient himself, and you have a window too, like Nima said, 7 to 10 days. The sooner the better when you get it in. And Asim Ali really pioneered a lot of this information, so kudos to him. But they show that when patients wait longer than that to get their AMT, you kind of miss the boat there. Like Nima said, you're standing on that cliff and you have to do it. So sometimes we have to do difficult things in life. You got to go for it. It's the right thing to do. So you should take care of it right there.
And the question from the audience that I think is worth answering outside the chat box is about the orientation of the membrane.
Yeah, so that's a good question. So the amniotic membrane typically comes, like the frozen amniotic membrane, it comes stuck on a piece of paper, essentially. And it's important you do have to maintain the orientation. So you want the stromal side of the membrane, so the side facing the paper, to be placed on the ocular surface, or whatever surface it is that you're treating. So, that is a little bit tricky, but as long as you're aware of that, and, as per your earlier question, John, it is pretty sticky and stretchy, this paper. So I didn't just remove it all. I kind of remove I peel what I need to, place it on the upper eyelid, sutured, and then gradually kind of peeled away more as I needed to. And that also helps maintain the orientation.
All right, well, thank you very much to all our presenters. Ellie, Ahmed, and Dr. Nunde, great job this morning. We have comprehensive ophthalmology next week with Dr. Sitt. Looking forward to that. And have a great weekend, everybody.
Perfect. There's a quick comment here from Elaine Wu asking for the link to Hall's cornea session. These are all available on the DOVS website, and I will be sending out an email this morning with a link to last night's rounds. You can access all of those previous rounds, including Hall's session, through the DOVS website.
Oh, and Deep, I don't see the evaluation on the chat box yet.
Yes. Thank you for the reminder. I'll put that in, so I won't end the meeting just yet. Good reminder. Thank you. I was so enthralled with the with the topic that I forgot to put that in. So that's coming up. 1 second.
I just want to thank everyone, thank the university, and also thank the residents for doing such a great job presenting. And yeah, thanks. That was great.
Good job.
Thank you, Nima. Thank you, Ahmed and Ellie. You guys are awesome.
Well done. Thank you.
So here's the link. Sorry for the delay. So for anyone who, actually for everyone, but definitely for CME credits, there's the eval link. So thank you. Thanks for the reminder. I won't end the meeting just so everybody has a moment to copy and paste that.
Thanks again. See you next week.
Hey guys.
Are you still on, Amandeep?
I am, just because I was delayed getting that link out, so I want to make sure people have an opportunity to copy it.
Yeah. Okay. Good. Good to talk to you, man. How about them Blue Jays?
Hey, the young guys look good.
Yeah, yeah. If we can get Springer in, that would be quite a potent lineup.
I know, man. So it's kind of disappointing to you get this free agent and he's injured right off the bat.
Yeah, but you know, it's good that they're developing themselves. I mean, they're in it's opportunity for the other guys, and then when he comes in and plugs in, I mean, he'll plug right in. He's such a good player. It's going to be it makes everybody stronger and makes the lineup deeper, right?
For sure. And we almost had Michael Brantley, and I saw him last week with the Astros.
Yeah.
Would have been nice to have that back too.
Yeah. Oh, it would have been nice. Would have been nice to have Lindor too. He's not having a great season, but he's it's okay. Did you see that thing with the rat and the raccoon with him?
No.
No, it was really funny. He got in an argument with his second baseman over I forget what it was, some play in the infield. And anyways, I guess they had some argument and it was quite heated in the dugout, and a whole bunch of people had to break it up, and they interviewed him afterwards. What was it all about? And he says, "Oh, we were debating whether it was a rat or a raccoon in the back of the clubhouse." It's funny.
Good answer.
Yeah, good answer. Yeah. So anyways, great job, man. Really appreciate you're doing amazing work here. So I guess we'll talk soon. I will leave the meeting.
Yeah, man. Have a great Friday. I am going to end the meeting now. I think everyone's had a chance. So happy Friday to you all.
Yeah, thanks, buddy. Take care.
Bye.